Hi, welcome back to season 3, can you believe it, of DeBakey CV Live Sisterhood and Surgery. And we are coming back with a very hot topic, workforce shortage. Where have all the nurses gone? I have my co-host Palma Shaw with me today, and I will introduce our first guest who is here with me live, Gail Vozzella, who is our Senior Vice President and Chief Nurse Executive at Houston Methodist in Houston, and she joined here in May 2021 as Senior Vice President, CNO, and Crowning Achievement Centennial Chair in Nursing Excellence. Since joining Methodist, Gail has championed projects to improve nursing leadership education, increase the focus on standardization of education and nursing quality, and create opportunities for nurses to take protected time away from the bedside to explore nursing research projects. She is passionate about ensuring that Methodist maintains its established reputation for nursing excellence. She began her career in nursing in 1985 after earning a BSN from Boston College, and she's a tenured nursing leader with a career spanning both adult and pediatric hospital quaternary care systems. In May of 2022, she graduated with her Doctor of Nursing Practice Education at the University of Texas School of Public Health. And Gail has a passion for creating the right environment for nurses to have all they need to provide outstanding patient care. Welcome, Gail.
Thank you.
It's really a pleasure to have her today. She's the president of the Society for Vascular Nursing, which is closely related to the Society for Vascular Surgery, and that's how I've gotten to know her. Through her 30-year nursing career, Nancy developed a vascular expertise supporting vascular surgeons in the outpatient setting, where she orchestrated multiple community and professional events geared towards peripheral arterial disease awareness, prevention, and treatment. And as a president for the Society for Vascular Nursing, she is passionate and as an ambassador for PAD education and collaboration. One quote from her is that her experience as a certified vascular nurse, coupled with her holistic nurse certification, brings a very comprehensive and integrated approach to the care that she delivers. Nancy's been engaged in numerous initiatives, including the annual vascular education conferences for nurses and allied health care professionals, the Society for Vascular Nursing annual conference, serving as chair in 2021, along with her very important role in collaboration with the Society for Vascular Surgery. Welcome. Thank you for attending.
Thank you.
Hi, Nancy. And our last guest is Shawna Butler, who is a nurse economist and managing director for Exponential Medicine Conference and the creator and host of See You Now, which is a podcast produced in partnership with Johnson & Johnson and the American Nurses Association that features human-centered, nurse-driven solutions to address our most challenging healthcare problems and transform our healthcare systems and practices. Her career centers on raising the visibility of nurses, empowering them as system-level change agents, and recognizing how they create and drive clinical and economic value. She initiated a global conversation highlighting the rarity of nurses in boardrooms, product designs, innovation teams, policy development, tech conferences, and health media. In 2021, she was honored by Rock Health as a top 50 in digital health. Welcome, Shawna.
I am so glad to be here. And this is a really urgent conversation, so thank you for centering on it.
Yes. Well, Palma, we'll let you start with the first question.
Well, that's perfect. So really, Linda and I thought of this one day. We're talking on the phone, and my sister's a nurse, right? And I hear all these things about what's going on from her at, different family events. And we said, this is just such a problem. We should talk about it. I mean, we need to know more about it. And I actually learned quite a lot about it. And we're going to learn more today from you experts in this field, people with boots on the ground that are trying to also work at higher levels to make things better for everybody, patients and nurses and physicians, actually. So really, I know there was a need for nurses before the pandemic. But why do you think that we're really at this critical need now? I mean, the pandemic is a little bit over, right? I mean, why are we here? Is it COVID burnout? Do nurses not feel valued? Is it the healthcare organizations that have failed to protect the nurses from different things? Maybe each of you could comment on that. I don't know if Gail wants to start.
Sure, I'm happy to start. And like most things, it didn't happen overnight, just like you mentioned. We've heard for about 20 years how there's a nursing shortage coming prior to the pandemic. And then the pandemic certainly escalated the nursing shortage for a number of reasons. First off is a lot of nurses that we knew were going to retired during or right after that pandemic. And then the other thing that's good for nursing is a lot of other opportunities opened up for nurses, just like for physicians in the virtual environment and the tech environment. And nurses with a lot of clinical expertise were highly recruited to those positions, which is great for nursing. Just like Shawna mentioned, nursing having a voice outside of a typical healthcare environment is a good thing. Unfortunately, as a hospital administrator, it certainly drained our workforce very, very quickly. So it wasn't that we didn't know it was coming, it just that it happened much more quickly than we could ever imagine. But with that too is that the input of new nurses too certainly kept at the same trajectory. However, their training was much different during the pandemic. So just as medical students were not allowed to enter the hospital during COVID-19, neither were nursing students. So the other confounding factor that has hit us hard is a lot of nurses came in having never seen a patient, just in simulation, which then those nurses required additional training, additional support. So that was another factor that really led to us doing things like shutting down more beds, probably shutting operating rooms down in order that we could provide safe patient care with not only the number of nurses we had, but the amount of training that was required so they could continue to provide good care. So we had to really regroup as hospital administrators, in particular chief nurses, and really look at how do we do everything, which can be, a challenge to do it fast, but it also is a huge opportunity for us because we had done things the same way for a long time. And so to look at how does training happen? Does it happen centrally or does it happen all the time at the bedside? And we had to really shift a lot of resources closer to the work at hand, which is a good thing for nursing. Nursing having training all the time in order to keep that proficiency and skill set is good. The struggle that you all as physicians I think are experiencing is that drop in tenure. That's going to take a while to recover from, and we're going to have to hit it hard in order that this generation of nurses doesn't feel that they're ill prepared or that they're letting all physicians down or patients down. So training, is of course beyond just the nursing administrators, nursing educators. It really requires help and support from our physician partners because training we have to really drive a lot of support right now to the bedside nurses so they feel part of the team, they feel invested in order that they don't continue to leave the bedside care.
Yeah, we actually just at our last annual conference, that was our last, we had a Q&A with some of our experts, and we just talked, it was open mic, and we just talked about what are people experiencing and where do we think we're going to go and what sorts of things can we do, and it ties in beautifully with this. And that everyone's story is different yet very similar. We heard from nurses who, one nurse walked into work one day and found out that her unit was converted to the COVID unit, and they literally found out on the spot that this was happening. So, and then another nurse was just talking about the fact that, it used to be that she used to be able to spend time holding patients' hands, and now they're literally instructed not to, spend as little time as you can with patients. And that broke her heart. And she's like, I can't, that's not why I became a nurse. Another nurse was a new grad. And she said there just wasn't anybody there to support her. There's no mentorship. There's a mentorship program, but because they were so short with staffing, there was very limited motion in that. And I just reflected back when I was first, in 1992, without my mentors, I can't even imagine having my career start in an environment where we were upside down. But having said that, that is one of the points I was going to bring out, that, this isn't new. We've done this before. There was a shortage in 1988. And I remember when I was a nursing assistant in the intensive care unit and having, I think we'll talk about that coming forward, but having pool nurses coming in and then having to strategize, how are we going to rectify this, because it's not sustainable. So these are the topics we were talking about, is, some of the nurses didn't want to go to travel or pool nursing, but how can they keep up with the demands they have, the pay they have, and things just really have shifted. So it was great conversation. We had really nice brainstorming ideas of what can we do going forward. One point that I am firm believer of, and it's one of the action plans for our society this year, is really, we talk about self-care, but without really diving in and doing the work, resiliency is just critical at a time like this. So not just, exercising is fantastic, nutrition is excellent, but really doing some more of that mindfulness and really honing into purpose. When we're focusing on our purpose as nurses and why we became nurses in the first place, windows of opportunity seem to happen, to open, and collaboration then becomes more powerful and great when we're working together, sharing our vision. So in summary, we really had, it was a positive discussion of how we've done this before. We've been in a crisis before, but creative, strong energy and working together for a common goal always creates great outcomes. So I think it's going to be interesting to see how we evolve after this.
I agree. We have to help each other.
Yeah.
Anna, what do you think from your viewers and your other industry-related perspective?
Yeah, I want to zoom out and hit a couple points really hard. And the first one is, these issues predate the pandemic. We've said that, but we don't say it enough. And I say that because we're in this crisis moment, and whenever we have a crisis, we love crisis. We are really good at responding to drama and trauma. And as your comment earlier on, opening up about where we are in the stage of the pandemic, we're not done with this pandemic. There are hundreds of people who are dying every day of COVID. We've got another round that's coming through. So to think that we are done, we're not. The crisis phase feels like we're accommodating it. And what happens when we lose the crisis, we lose a sense of urgency, and we will go exactly to where we have been for the last 2 decades of not investing in the pipeline. We also, I want to make very clear, we talk about a nursing shortage, which is very different from nursing vacancies. And mostly what you're experiencing right now are vacancies. Shortage means there are not enough nurses. That solution looks like, how do we create more training opportunities? How do we have more nursing faculty? And the fact is that every single day or every year, we are turning away 80,000 qualified candidates who want to become nurses. We don't have clinical spots for them. We don't have nursing educators. So this shortage thing, that has more to do with demographic trends. The crisis phase that we are experiencing right now is a vacancy. We actually do have quite a few licensed professionals at all sorts of different levels. What the vacancy says is, I am not willing to work in these conditions with this set of unrealistic expectations for an economic trade-off that really, there are better opportunities in the market. And why has that happened? Because we've lost trust in our leadership. We've been asked to do things that are not safe. We haven't been given the staffing that is required, and we haven't been given the training. And when when Gail mentioned that we have, every year, we know that just aging, we're going to lose the tail end of our nursing workforce. We have this pipeline that comes through. The thing that happened in 2020 and 2021, we have never seen before. We lost more nurses on the front end of their career, those nurses under 35, which means that entire set of pipeline, we're not going to have another 20 years. The other thing that I really want to focus on is when we talk about shortages or vacancies, we talk about nurses as a monolith, as though it's a set of numbers. And as we all know, it's a set of expertise. And every time we lose nurses who have 10, 15 years, we lose institutional knowledge, we lose clinical knowledge, we lose the skills of being able to teach and to train, and a lot of that intuition that you only gain by practicing. So this idea that they're interchangeable, and again, we talk about them in very large aggregate numbers. A vascular nurse is very different than a mom and baby nurse, which is very different from a burn nurse, which is very different from an outpatient or a school nurse. So the key messages is that every single one of these places where nurses practice, where people count on a healthcare system that is reliable, that is accessible, that is safe, that is actually caring, we don't have the numbers or the experiences of nurses that we have had in the past. And our health systems are in critical condition. And that means we have to invest. It's going to take money. And also, these things don't happen overnight. That's why the investment is critical now, because it's not like you turn out a widget or you create a new app and then all of a sudden you release it out into the market. To train folks, nurses, to be competent and confident in those roles requires time and people and money. So you ask, the problems. I think it's really important to know that these are long-standing, multifactorial, but they are entirely fixable. And when I tell you that we have 80,000 people who want to come in and practice, that is the thing that we should be focused on, is like, okay, there are a lot of folks out there. What do we need to do to engage those? And for those who are currently in the practice, what do we need to do to keep them safe, to feel protected, for them to have a trusting experience, for them to actually be able to practice? I mean, when nurses leave, most of the time what they're telling you is, I don't feel like what I'm able to do is deliver safe care. I don't want people to be hurt. I don't want to be hurt. I don't want to be legally liable for any of these things. And that's why it's really important to distinguish between a vacancy and a shortage.
So on that note, well, real quick before I forget, this is a live show. So remember, if y'all have questions, you can join by web, go to pollev.com, enter DeBakey, and send in your question, or join by text through your phone, text DeBakey to 37607, and we will try to get your questions answered. And speaking of, feeling unsafe, I mean, Palma and I were doing research on this topic, and, the violence in the workplace, like 2 nurses, get assaulted every hour. Most of the time it's
reported.
Yeah, exactly. Yes. And that's, again, like, a NICU nurse versus an emergency room nurse, more likely the emergency room nurse. But what are, and I also, like, in terms of a national government level, like, is there something that should protect nurses? I mean, we are always like patient first, but at the end of the day, I mean, just like surgeons, it's if we don't take care of ourselves, we can't take care of other people. And so do y'all have comments on how that can be changed, and how nurses can stay protected and also hold patients accountable without it being that awkward, well, you're our patient, but you also spit on us. So
I can start us off. Again, as it didn't start during the pandemic.
It didn't, right.
That violence against nursing has been there for a long, long time, certainly similar to nationally. Mm-hmm. What's happening nationally, just in general in our country, is violence has escalated. And I think what nurses saw during COVID was initially there was so much community support for the work that they did, and the patients pre-vaccination coming in to the hospital environment were very grateful that our nurses in general were taking good care of them. What was another very distressing factor that caused some of the turnover, I believe, was post-pandemic, when we had vaccination, people were coming in with COVID that were not vaccinated, and a lot of their anger was directed at the nurse. So nurses had questions, directed toward them from their patients of, are you sneaking in a vaccination into my IV? Or, I don't believe in vaccination, I don't believe in the care that you're giving, but meanwhile, as
It's your ear.
nurses, similar to physicians, is we have a duty to provide that
Yeah.
care. So again, it's if you have a lot of experience as a nurse, those conversations can be really tough. When you are a nurse that's 2, maybe even 1 year into your career, those are very traumatic conversations. And so here at Houston Methodist, we did provide a lot of support with many different types of rounds in order to help talk through those discussions and offer a lot of one-on-one counseling for nurses because it's very traumatic. So it's not even just the physical hit, it's also somebody questioning your care in a time when you're very new in your career. And that can be very distressing. So now even for our new graduate nurses, we offer employee assistance in just even counseling, psychological counseling to nurses before they even see a patient. Because what they experience now is very unique, unfortunately, from when I trained initially as a nurse. But you have to keep at it, and you have to develop. There is more advocacy. Because, as Shawna mentioned, is we have a window where we have a crisis. So nurses speaking up nationally to say is we will no longer, be assaulted by our patients has brought national awareness to it. But certainly we have a ways to go. And most of it is handled at a hospital level to say is, you can't treat our nursing staff a certain way. And if you are, is that you're not welcome to be a patient here. But those are very tough conversations because a lot of people, require our care. So it's a challenge. It's not easy.
Yeah, on that, there's federal legislation that has been proposed. And I think the public is far more familiar with this violence from the general public, what we've seen in air traffic, when we've seen in aviation, where we've seen this 300% spike in violence against or unruly passenger behavior. And there have been very swift penalties. You cannot come onto this flight. You're going to be blocked from all these others, fines and penalties. That really has not existed in our healthcare settings. And part of this has been oftentimes patients, a lot of this happens in psychiatric units. And so maybe they are not fully aware of what's going on. Clearly, in emergency departments, there are oftentimes high levels of emotions. And so it's been not a clear line oftentimes. And then we have not had administrations that back it up. But I think that we need to move further and further upstream on this. And how are we creating civil environments? What are we doing as far as calming measures? Because oftentimes when that unruly behavior or the violence or the verbal assaults break out, it's a sign of a lot of frustration. And it's the frustration within the system. It is, I've had to wait too long. I am in pain. You're denying me care, on and on and on and on. And it manifests itself in a moment of great vulnerability when somebody is there with you that is more vulnerable. And so if we look at de-escalation measures and we're creating environments and systems that anticipate and that do put protections in, and then yes, if people are misbehaving and creating problems and when we talk about violence against nurses, we're talking about broken jaws. We're talking about hospitalizations. We're talking about nurses, and it's not just nurses. This happens with all of our staff, anybody that works in these environments. There's loss of life. There's loss of their ability to practice. So it is a significant problem on the end of what ends up happening to people. But the other part is it has that real chilling effect where nurses don't feel safe. They don't want to come and work in that environment. They're not comfortable taking those risks. So, and then, when you see that or you hear those stories, how is that becoming an attraction for people to want to come in and work in these environments? And I think that's one of the things that we all wanted to make sure and highlight is when we share with you, Palma, you had mentioned, we need to have these discussions. You were having discussions amongst your peers, like, we need to talk about this. The real challenge that we have is when we talk about it and we do share what the problems are, how do we do it in a way that doesn't dissuade others for coming in and being a part of this really beautiful, important, rewarding work? There are very few things that you can do as a career choice that have such great purpose, such great meaning on a daily moment-to-moment basis. And so I always want to make sure that we're couching that while we are sharing these problems, and we need a lot of the youth, our next generations, we need their energy, we need their stamina, we need their ideas. So I don't want to scare people away, but we still need to have this conversation about what are the realities of the situation.
Nancy, do you have thoughts on how we can improve the violence and who can be held accountable for that?
My thoughts on that have been touched upon as well. So really, when you look at reasons that nurses are leaving the position, and I too was doing a little research too, it's just that I was reading that they want to come back, but it's just the unsafe staffing and unsafe environment that keeps them away. But really what they would just need to know that their voices are heard, and in their, again, leadership. And when staff members and nurses and everybody for that matter, when their voices are heard and leadership is adjusting to what their requests are, and they know that it's not dismissed, I think that goes a long way. We all know that we can't change what other people are doing and what's happening, but we feel better in knowing that that our voice is heard and that action steps are being taken. And also the support that we get from one another. We're not alone in this, and together we can overcome this. I just know in previous roles, we had a lot of turmoil with crisis in the city, and we had the National Guard there protecting us, and that meant volumes. It was scary going to work, but we know that administration took that very seriously, and they provided us the support we need. So I think there again, leadership just goes a long way.
I do want to follow up on that, Nancy. Your point about being heard. That is just the beginning steps. And for too many times, I think nurses have felt like, yeah, we've spoken up, but you didn't take the action. So the action at this point is really the key piece of this, is taking action. There is no more need for data, for evidence. We're well beyond that. Action is required.
And I think part of that action, Shawna, I think there are steps being taken, and I think it's moving faster, which is great, than ever before. So for one, as we've talked about for a long time in nursing, is to work to your highest level of your licensure. So a lot of times as nurses, I've heard nurses say is, well, the nurse just left that room. Why don't they just clean the bed when they were there? Well, we would never ask, respect in this room is that we would never ask a doctor to go ahead and clean the bed. And it doesn't require a nursing license or our training in order to do that work. So it is a good time, again, taking advantage of where we are very highly sought after. We are valued members of the healthcare team. Is why don't we re-look at the members of our team at the bedside? So there's been some talk from nursing CNOs of, well, why don't we go backwards to when we had LVN and an RN work together, and they had 10 patients or whatever it was. Well, there's no need to go backwards. We don't need to go backwards. We just have to look at what does the healthcare team look like, and what lets the healthcare team work that the nurse is working to the highest level of their licensure. We have to unburden the work of the bedside nurse. So it's not just about more nurses, it's also about let's let nurses do what we all went to school to do. Just like you talked about, is holding hands of patients, listening to patients, deciding if a patient is well or sick or getting better or getting worse, and putting all those factors together. If a nurse is doing all the phlebotomy for their patient care assignment, they can't see if a patient is better or sick because they're just doing tasks. So removing tasks, getting deployed in phlebotomists, mobility techs, respiratory therapists, and a whole complement of a symphony together to care for a patient, including housekeeping, including transport. And so the nurse can be that coordinator of care. Now's our time. And the other piece is technology. So technology was initially in healthcare, I believe, driven towards helping physicians with robots in the OR and other factors. And then a lot of technology was directed towards patient safety, which is fabulous. It's great, except it added 10, 15 more steps to the bedside nurse. So a nurse used to just walk in and give medications. Well, now they barcode the medication, they barcode the patient, they go back and chart it in an electronic medical record. Well, that whole burden of workload was never really studied. If everything is so directed toward patient safety, did we add so many steps to the bedside nurse that, again, they're distracted from their passion for what we want them to do? So the great news is now there's technology coming to do just what we need, unburden the work of the bedside nurse. So things like ambient technology, stickers to monitor heart rate and blood pressure, virtual nursing, just smart ways of looking at vital signs that help us with alerts, getting rid of the noise of alarms. And we have to ensure that our nursing workforce knows that this is all about you. For the first time, this is about you. This is about unburdening you so you can do what you went to school to do. We're behind. We should have done this 10 years ago, but doing it now because we are in the spotlight, because tech is directed towards us, let's just go. I think it's a really good time to reinvent, not go backwards.
That's a great point. Yeah, a lot of the strain, with physicians too, is documentation. You spend all hours, and you see ICU nurses, do it all the time. Like, they're so busy with the patient, and then it's 7, they've done checkout, but they're still there an hour later because they're documenting all this information throughout the day, when honestly,
Voice activated charting.
Exactly. Something or automated systems where it just puts down, the average of the heart rate that hour or whatever, instead of the nurse having to be like, okay, let me write it down. So yeah, it makes sense. It would take
data entry clerks. Is that what you're referring to?
Well, actually, there's tech that's looking at.
No, what I mean by I'm being facetious.
Oh yes, yes, exactly.
Look at these highly trained, regulated professions.
Yes.
They have become high-paid data entry clerks. When I look at my physician colleagues, and the amount of time and that it holds things up to go finish doing your charting. So what I do think is interesting on the technology front is people oftentimes confuse digitization with transformation. We have been going through a very painful era of digitization. We can't get to transformation and really leveraging all of this incredible possibilities of having our moving into a digital approach, a data-based and evidence-based, I shouldn't say database, data-driven approach to surfacing and being able to do these really complicated searches and predictive algorithms to understand who's at risk for something, when might they be at risk, when do we need an intervention. So we are in this really uncomfortable, painful period of that transformation. And I think a big part of this is that recognizing that clinicians have not been the drivers and the designers of the technology that we need to help us actually care for people and communicate with each other. And right now, these tools have been designed as financial tools to look at activity and movement of resources and products for billing. They were never ever designed for us to coordinate and deliver really good data-driven care. It helps us, when we talk about an AI, that's really intelligence augmentation. How do I have this set of insights that now help me to understand what is actually needed here, and it actually improves my ability to care? So I'm hoping that we as clinicians can take a lot of the leadership of the technology, and instead of technology being in search of a problem, like, oh, I've come up with this really cool thing, maybe this will help you. How about if we take a look at the set of problems that we have, the criteria, and what are the technologies that are actually going to help? You know, Gail, you mentioned using voice recognition. The more we get to be in conversation with each other, and that ambient piece passively in the background picking up what that conversation was about, what was that meaning, and being able to present it back to us to say, here's what that clinical encounter looked like. Here are a couple of things that you might need to be planning for and anticipating. Would you like me to go ahead and put a call into so-and-so to get a consult or to check and see if their family is ready for them to be discharged? That is a pretty magical moment, and I'm super excited that we're going to get there. And more importantly, I want our clinicians to be the drivers of that technological revolution.
So that would really lead into my next question, really, is the economics of all this. I mean, everyone talks about AI, we can do these things better. I totally get that. But the reality becomes many of these hospitals are on shaky ground. Many have closed, wings are closed. Our OR is still restricted. You know, we're a state hospital, a private hospital with a large endowment could potentially have some income that may permit that advancement. So who's going to pay for this and who's going to drive it? How are you going to make this across the country in Iowa and Idaho and New York City and Houston? How do we make fair care and fair implementation for all people?
Yeah. The equity question is so important. Technology has a great way of solving problems and democratizing it, but also when it's put in place and just drives it, it can drive the disparities and accelerate them just faster, you know, so we need to be really mindful. And there are really key elements that are infrastructure investments. So part of this is one of the major things that we learned during the pandemic was the importance for high quality, low cost, easily accessible broadband. As we go to a digital first, we're going to need to make sure that everybody has access to that. Do they have devices? And then the next piece is there literacy? Do you actually know how to use all of that? And a lot of this is infrastructure investment that we're seeing. I think a lot of the technology companies, a lot of federal and state level investments have been made, and the dollars are there oftentimes. In the short term, it's tough. Let's just name it. It is really tough. But if we take a look at how do we use the technology that we have, and you think right now, really inventory control or being able to predict, you know, what patterns of illness are going to be, so that we can use that piece of data to appropriately and safely put together our teams and staff. And I wish I had better answers for you, or smooth answers. I think we know what the answers are, but they're going to be challenging. And what it means is that we work better together as teams. And one of the things that's been very clear from a lot of the legislation on this, the Lorna Breen Healthcare Provider Protection Act, one of the things that has been made very clear is how do we get rid of some of these burdensome tasks that have to do with documentation. And one of the things that we have learned during the pandemic was there are a lot of things that we actually they're not providing value. We need to really look at that and just stop doing it, get rid of it. We also need to think about how we work better together as teams. We also, I think one of the other real key pieces that we learned during the pandemic, you know, what Nancy was mentioning, nurses would come into, I think this happened actually with all of our healthcare team members. You'd come into your unit only to find out things have been changed. We're going to be taking care of a different patient population, and you may not feel comfortable with, you may not have the skills and the training. So how do we engage micro learning? How is it that we put together those teams to say, okay, you're the expert in a critical care setting, but that doesn't mean you don't have nurses who know how to set up all of the other parts of delivering that care. So we need to engage the technology to do better delivery of micro learning, in-time learning, simulation practice, and there are a lot of really good technologies for that. And Gail, you probably have several of them, and I'm sure, Nancy, that all of the nurses that you are in the society, these are some of the things that they're looking at as far as higher and faster rates of adoption, so that we can bring more people up to speed on competency levels and comfort levels.
Nancy, going forward, if you're going to set up next year's annual meeting at the VAM, for example, would any of this new technology be something that you'd like to discuss or target to bring to your audience? I mean, is this something that's realistic in 2022 or 2023, or are we talking 2030? I mean, what are we really talking about here?
I think interesting topic. We're actually just working on a project with evolution of vascular nursing, and really just going and looking at how nursing has evolved. And there is a nice article that we talked about that there's a difference between evolution and change. And I'm going to just go back to the grassroots for a moment, in that really, if you talk about Florence Nightingale, the mother of all nursing, she really honed in on the spirit of nursing, and it's a calling and a purpose. And going into a global level, it's the Nightingale Initiative for Global Health, and it's a conglomeration of people all over the world working together to address, and that was back from 2006. So my point being, we can call upon resources that are already there, and we can create an evolution landmark. And definitely, I think these are things that are worthy of conversation, but wanting to just really reiterate the fact that if we're sticking to really what brought us to nursing, again, I just can't speak high enough that there are windows and doors of opportunity that open. And with the Society for Vascular Nursing, some of the things that we're doing to hallmark this is, we mentioned we have our mentorship program, we have collaborations with SVS, so the resources are tenfold. The other piece, and I'm throwing this in there, I know it wasn't your question, but I just feel like it's important, and I just want to bring it up, is that really nursing and value, we all want to feel good about the work that we do, and strategizing, where do we go from here? Simple gestures of kindness. I just went to a global leadership, and every leader spoke of the benefit of kindness. And for me, working in the clinics when it was crazy and we were short-staffed, what meant most to me over anything and kept me coming back is just a simple message from my provider. I might get a text message saying, I would have been lost without you today, or you put a Reese's peanut butter cup on my desk. I mean, simple acts of random kindness go so far in keeping nurses and bringing nurses back, knowing that who you're working for sees what you're doing and the value and acts on that. It goes tenfold. So yes, to answer your question, I think these are topics for going forward in technology, how we've advanced so much. Short story where we went and we created a brand new vascular program not too long ago, and we had these fantastic surgeons come into the program, and it took a lot of extra training to get the units and the OR staff ready, the post ICU beds, nursing prepared, in that with all these advancements that we're making, along with that comes opportunity for nurses to expand and spread their wings and fly. Really, it's up to us. Going back to Florence, she wrote in the 1880s that it would take about 150 years for nurses to come in and change the way we deliver healthcare. Well, that's us. So I think that we're going to go really far in how we evolve, and great topics for future conferences. I think each year we can add more layers to that.
So we have a few questions from the audience now that we're getting down to the last 10 minutes. The first one is, judging from your observation, what is the major reason that makes nurses leave the workplace?
I can start us off because I'm probably the closest to it. It is a struggle to know exactly why, because of course on leaving, people don't always tell you why they're leaving. And also it's an evolution. Somebody may leave their position and think it's for one reason, but after they're out for a while, they're like, well, gosh, it was that mental toll, or I felt uncertain of the care I was providing. So some of it we don't know. But part of it is that nurses do know that they are a commodity now, of that they're very sought after, and that there's a lot of opportunity. So in a generation that isn't like when I graduated in 1985 that my dad was disappointed that I didn't stay at my original job in Boston when I graduated, because I only stayed a few years, and he was like, how could you leave them, after such a short period of time of 3 years? And now people would leave, a lot quicker. So I think that part of it is right now is there is a lot of movement, and it's sometimes it's both a husband and wife are moving, or that somebody has just sought another opportunity up, somewhere else. But I think it is, if I was to pick one reason that people are leaving bedside nursing, it's the workload. And so we have struggled to get traction on getting that right workload for nurses. And it, on top of a time that there's a lot of mental stress, is that workload has caused more nurses to leave. So unless we get traction on the volume of work that a bedside nurse is doing, I think we will struggle with that volatility, and the sooner we get our arms around that will help. And as Shawna mentioned too, is getting more nurses through our pipeline in a more efficient way, that they feel their transition to practice is safe, they feel welcomed in our environments, they feel like they have lots of people around them to provide good care.
I talk with nurses all over the world, all types of settings, all types of specialties. I think it's important to understand those who are leaving the profession and those who are moving to different opportunities. When nurses tell me that they no longer want to work providing clinical care as a nurse, it really comes down to it's unrealistic in the work. It's too hard. It's just too much. It's not cognitively hard. It is the expectations are unrealistic, and I am worried that I will hurt someone. The stress of not having the resources that I need, not feeling like my employer actually cares, that is why they leave. I think a really important question to ask is, why do nurses stay? And the reason why nurses stay, what we hear, is they stay because of their teams and their colleagues. It's actually not even the patients. Mm-hmm. It's they do not want to let their colleagues down. They have pride in their work, they have pride in their unit, and it is amazing when you have leadership that supports you, that sees you, that appreciates you, that compensates you. Nurses will too. I think that's true for anybody, but that's the reason why they stay.
What's the
That's
culture?
the reason why they stay.
It's the culture, right?
I would just say another really attraction piece is when you are able to actually affect change. So in that, when we were talking about technology and we're talking about innovation, when you see a problem, when you see a gap in care, and you have a leader, the first word out of their mouth when you go and say, hey, I've noticed this, can we work on this? The first thing out of their mouth is, good on you for having figured that out. Yeah, don't know how we're gonna do it, but yes, let's work on this. So when you are given the space and the time and the support, the encouragement to actually be a problem solver, that's why people stay. That's why they want to do this.
And Nancy?
Yeah, one thing I'd like to point out too is going back to the sense of feeling value and simple gestures that go a long way. We just had a nice blast during Vascular Nurse Week a couple of weeks ago, where the costs of being involved in societies, and we want to promote that. We want people to be involved in professional organizations, and that's going to help you get through some of this. But when they're already feeling strained and there's finances, and sometimes programs have even cut some of the education funds and reimbursement funds. So we're trying to find ways to remedy that. How can we get some support for some of the annual dues and registration costs for conferences? Our big blast was just recently requesting and putting an invitation during Nurse Week for vascular surgeons to cover the annual due for a nurse. And we just in that week had 10 surgeons cover their nurse. annual do. So it's things like that that we're trying to encourage collaboration and just that feeling of belonging and having somebody there that's going through the same things that, we're in it together. And that was that. And then like a member spotlight, we call out one of our members each month and we do a little shout out for them. We have our little round tables where we can have discussions similar to this. And I think that really is a key factor, and that we've heard from other nurses who, gosh, I wish I would have known about SVN before. This is exactly what I need. So we've had great responses to the work that we're doing to try to promote and promoting wellness too. That's key in all of this.
So I think we have just a few minutes left, and we just really want to get to this one question, and I want to hear each person's thoughts on this question is, for the future, these future nurses that you're saying you're waiting to beat down the door, trying to get in and do take good care of patients and do what we love what nurses do, right? Do everything that they do. What can we tell young people? My niece, the first 2 weeks of nursing school, first 2 weeks. So what can you say to my niece about to get her through it and encourage her? And she's wondering, what's in this for me in the future? What can I look forward to? Maybe you can just look forward and have a vision of what they can look forward to.
I'll go ahead and start with that.
Yeah.
It is an incredible career from the standpoint of the breadth of things that you can do. For my own, I will just say one of the things that I love is there's nothing more uplifting and really soul satisfying than being one-on-one with somebody. But then I really like to zoom out, and with technology or with policy, I'm taking care of millions of people at a time. And so the range of things, the career expansion, the career type of growth, and as far as new folks coming in, I think a big message that they need to hear is we don't have really good established paths outside of hospital settings for how you develop a career that would include all of these different things. And I would make sure to tell people, go find your specialty groups, go find your state nursing association, find your specialty nursing association. Those are key in developing longstanding relationships, figuring out really interesting career paths, and making sure that you keep those clinical skills. You look at it from a career longevity standpoint. Your core thing is clinical expertise. And once you have that, you can start looking at how do I affect a program? How do I affect a policy? How do I inform a technology? And finding those ways to combine it. I think that that's really what this next generation is coming in. They're digital natives. They can teach us a huge amount. And to be reminded that they're the fastest license to the patient, which means they should be on the front end of any new technology or business model. We need them there and to stay with it and help us grow it and develop, and particularly being leaders to those people who are twice their age and don't look anything like them.
And I would just add to that, Shawna, that being a nurse, I feel so grateful that I chose this career. And I would just give advice to anybody starting in their second week of nursing school is you don't have to know what type of nurse you're gonna be or what specialty is. I have done the gamut. Other than operating room, I think I've done it all. And so, but it took me a long time to figure out that, where I belonged and what type of nurse as a specialty I wanted to be. And then all of a sudden I got involved in leadership and in nursing leadership. And as Shawna mentioned, I would have never thought, I loved being a bedside nurse. So I never thought I would end up being a leader, never mind a chief nurse. But your ability to impact others in a different way. So it's okay to try different things before. You don't have to know exactly what you want to do when you're starting out nursing school. Just take it all in. But the seeing people, physicians see people, of course, at a very vulnerable time. But nurses, we're the ones, with that patient, we don't come and go, we're there. And so I feel so grateful that at people's most vulnerable times that I was part of their family. and I help get them through a time that most people don't ever see. And I feel that that was not only a gift to them, because I really tried to give it my all, but also it was a gift back to me. It helped create who I am and probably helped me get through different challenges in my own life, because at a very early age, I saw people at a very vulnerable time, and it was a really special gift.
I'll jump in and I'll be brief with it. I know we're close to end time here, but I can't emphasize enough the importance of taking time for self-reflection. We are so busy as nurses and everybody doing. We forget to take time for being. Being is where we develop our sense of discernment. Discernment is where we learn our purpose. Purpose then is where we set our goals, and goals takes us to the destination of where we want to be. And I can't emphasize enough the value of leadership. Every single one of us is a leader. If you have a thought, if you have an idea, lean into it, take steps, and make it happen. We are the future, and without creative juices coming together, it's not going to happen. So take that step and make change that you have.
One last thing I want to tell those second week students, thank you. Thank you. We need you, and you got this.
Well, that
I am
is
so
a
sure they will be so fired up by this conversation, and I can't wait to hear what she thought about the show. Thank you for everything.
Thank you so much.
Thank you so much for having me. What an honor.
Hopefully
Really enjoyed
we've
it.
made an impact, and people will have more awareness of and appreciate y'all more for what you do. So thank you for taking your time and giving us your thoughts on this topic. Good night.
Have a good
Night. Thank you,
Yes.
everyone.